All right. So I figured that I would come through and go through alpha now, just so that way we have more time later on. Um, so alpha receptors. What we have going on is we have the alpha 1 receptor, which is GQ linked. And whenever you see GQ, I want you to think smooth muscle contraction. Alternatively, for alpha 2, this is GI. And what we see with GI is two different effects. The first effect is that we decrease cell production. So whatever product that cell is making, activating alpha 2 is going to lead to less of that product. If the alpha 2 receptor is on smooth muscle, then we also have smooth muscle contraction. But it's through two different mechanisms. And understanding the difference between these mechanisms is super, super important. So let's take a look. When we look at a smooth muscle cell, so here is a smooth muscle cell. We know, based on what we talked about with beta, that in order for it to contract, the myosin head is phosphorylated via ATP. So ATP interacts with the myosin head, which phosphorylates the top and causes the muscle contraction. So what we have created is, so here we have a phosphate group, and we have our post-contraction myosin head. The way to think about this is that here we have an active myosin head ready for contraction, whereas over here we have an inactive myosin head that's post-contraction. The myosin head can be dephosphorylated and have that phosphate group removed in order to recover it to be ready for the next contraction. So the myosin head interacts with ATP, boom, contraction happens, then dephosphorylated, now it's ready again, boom, and back and forth, back and forth, back and forth. And every time it goes through this cycle, a contraction happens. What we know is that inside the smooth muscle cell, we have the sarcoplasmic reticulum, and we also have, no, use that color. We also have calcium channels allowing for calcium to flow into the cytoplasm. When calcium comes in, it interacts with calmodulin, where it then activates the myosin light chain kinase, which really all you have to know is that calcium causes a contraction. Boom. So on our smooth muscle, we are able to have the alpha 1 receptor, which we just talked about is GQ coupled. And we know that this receptor is going to cause phospholipase C to convert PIP2 into IP3 and DAG. IP3 is going to enable more calcium to be released into the cytoplasm. So we get even more. Where DAG is going to work on phosphokinase C, which is going to increase the action of phosphorylating the myosin. Overall, we are going to increase contraction. We're going to make the contraction stronger, and we're going to make it happen more often. The flip side of this is looking at alpha 2. Now, normally what happens in the body is you have CAMP, which activates PKA, and PKA keeps the myosin head phosphorylated. So what PKA is doing is that it prevents additional contraction. So in other words, by keeping the myosin head in its inactive state, what it's doing is it's preventing the next contraction, which means that it's promoting relaxation. Now, what is alpha 2 doing? Well, we know that alpha 2 is GI linked. So it's going to come in and decrease CAMP production, which means we're going to have a decrease in the action of phosphokinase A, which means that we're going to decrease the amount of inactive myosin. So what alpha 2 is doing is it's inhibiting relaxation. It's not causing contraction, it's inhibiting relaxation. The overall effect is that both receptors in smooth muscle appear to cause contraction. One is through direct action, the other is through indirect action by inhibiting the pathway. All right. Let's move along. And let's talk about alpha 1 and its locations and its uses. Is this the right color? No, wrong color. Alpha 1. So we cannot draw it in straight lines. The first place that we're going to find, of course, we're talking about activating alpha 1, which would be an agonist, and inhibiting alpha 1, which would be an antagonist. And the first place that we're going to look at is the blood vessels. Now, we already have one receptor that we've talked about previously that exists on the blood vessels, and that's beta 2. Beta 2 exists only on large diameter blood vessels. Whereas alpha 2 exists on large and small diameter blood vessels. So what that means is that we have much more control with blood pressure using I don't know why I wrote alpha 2. This is alpha 1. We have much more control over blood pressure using an alpha agonist than we do using beta 2 agonist, right? Because both of these are GQ linked and going to cause contraction. So if you activate alpha 1, you are going to cause vasoconstriction. If you inhibit alpha 1, you cause vasodilation. So what ends up happening here is that when we use an alpha 1 agonist, we're using it specifically for its ability to contract all of the blood vessels in the body, everything. And so one of the first indications that we're going to be using this for, vasoconstriction, is something like orthostatic hypotension. Orthostatic hypotension, which is a condition where the blood pressure is too low when the position of the head changes. So for example, when you go from a sitting to a standing position, the elevation of the head changes pretty rapidly in a pretty quick movement. And so what that means is that the body needs to work harder to fight gravity and send blood upwards to the head. So orthostatic hypotension is a condition where someone is not able to adjust their blood vessels quick enough in order to get enough pressure to send it to the brain. The result is they get really dizzy, they might even pass out. And often we see this with older people, and the result is that they fall, maybe they crack their head open on something, or they break a hip, and then it's, you know, a really, really, really bad situation. One of the drugs you'll see here that works, that we use specifically for orthostatic hypotension, is midodrine. Midodrine is a prodrug. It's activated in vivo, but it does a great job with helping with this orthostatic hypotension. The other thing that you'll see alpha 1 receptors used on is nasal congestion, stuffy nose. Inside the nose, so you have your nasal passageway, and the nasal passageway is surrounded by blood vessels. And so what can happen when you get sick or you know, allergies, different stuff like that, is that the blood vessels can get very, very wide. And if the blood vessels get wide, they're going to constrict the space in the nose, and you're going to get congested. So we can use an alpha 1 agonist to decrease the diameter of the blood vessels, which will cause the diameter of the nasal passage to get wider. And specifically, the drug that really the only drug I've seen used like this is oxymetazoline, or you'll see it as Afrin. So two big uses for vasoconstriction via alpha 1. The first is hypotension. The second is nasal congestion. We're going to talk about shock in just a second because we need to compare a bunch of things, but we'll get there in just a second. In terms of vasodilation, but through inhibition, really what the what we're doing here is more of an adverse reaction. So the vasodilation is going to end up widening the blood vessels all across the body, which is going to cause a significant blood pressure drop. So really the use of alpha-1 antagonists for blood vessels is really limited to hypertension. So remember that blood pressure is a function of cardiac output and total peripheral resistance. And when we talked about beta 1, we talked about how total peripheral resistance is made up of the blood vessel diameter and the blood volume. And so what we're doing here is we're increasing the diameter, which is going to drop the resistance and going to drop the blood pressure. And that's really what the use of an alpha-1 antagonist is going to be in terms of the blood vessels, is sort of an adjunct to hypertension treatment. There is one big drawback to using alpha-1 like this. Now, we talked about how with beta blockers, we're going to cause vasodilation. And we're also going to, through beta 2, and then through beta 1, we're going to decrease the cardiac output, and we're going to decrease total peripheral resistance. So just to fill this all in, so cardiac output is a function of stroke volume, and it's a function of heart rate. So a beta blocker, beta 1 blockade, will occur on both of these parts to blood pressure, both the cardiac output and the total peripheral resistance. Cardiac output based on the myocytes, total peripheral resistance, mostly because of its effect on renin. Alpha-1 is only participating here. And because of that, we're going to see one major adverse effect to alpha-1. And that adverse reaction is reflex tachycardia. Inside the brain, there is the baroreceptor, which is responsible for checking the blood pressure in the body. So it is sensitive to the pressure exerted in that region of the brain. And when the blood pressure decreases, when blood pressure drops, the baroreceptor stimulates the heart to increase the heart rate. So your blood pressure goes down, and so the baroreceptor says, we need to get this back up. The fastest way to do that, make the heart beat faster. It's also going to have an effect on, it's going to, cause more renin to be released. And so that over time, you're going to raise that blood pressure. But the more immediate effect is we get that reflex tachycardia. For alpha-1, for alpha-1 antagonists, one of the major adverse reactions is this reflex tachycardia. These drugs are going to lower blood pressure by increasing the diameter of the blood vessel, which is going to cause the heart rate to increase to compensate. Why doesn't this happen with beta 1 antagonists? So with beta 1 antagonists, we get no or very minimal tachycardia. And the reason for this is that they are not only widening or they're decreasing the total peripheral resistance, but they're already blocking the heart rate, right? They're already working directly on the cardiac myocytes. So we don't get reflex tachycardia with drugs like metoprolol, propranolol, labetalol, all your beta blockers, because we're blocking increases in heart rate anyways. So hopefully that makes sense. All right. Moving right along. Next up, we have to talk about the urethra. So all along, so here we have the bladder. And then we have the urethra. All along the urethra, we have these bands of smooth muscle, which help with the release of urine out of the bladder. With alpha 1 activation, we get smooth muscle contraction, which means that we're going to get the smooth muscle to constrict the urethra. So smooth muscle constriction leading to urinary retention. Conversely, in I should have wrote that in orange. My bad. In blockade, we get smooth muscle relaxation, which leads to urinary release, is the way I'm going to phrase this. Because it's not really accurate to say that it causes incontinence. It's more that it allows for the increased urine flow. I think that's probably the better way of saying it. Yeah. So in activation, we get the smooth muscle constriction, decreasing urinary flow. Whereas in smooth muscle relaxation, we get an increase in urinary flow. Which means that what is the better, what's one of the uses of an alpha 1 antagonist? Urinary retention. So if someone is holding onto their urine, it's not coming out as much as we would like, then we can use this aspect of alpha-1 antagonist to help loosen the urethra. Now, the question is, can we use the smooth muscle constriction to help with incontinence? And the answer is not really. What is really driving incontinence mostly is the detrusor muscle pushing the bladder and squeezing the urine out, right? The detrusor muscle comes in, which will cause urine to flow out. The smooth muscle constricting through alpha-1 is really just cutting off the outflow. You're not doing anything about stopping the detrusor muscle from pushing. You're just making it harder for the urine to come out. And so really what you end up doing here is the person would still have the urge to urinate, but now they can't do it. So not great, right? Not great. The problem is an adverse effect of this is urinary retention. So we're not using this drug for incontinence, but we do cause urinary retention, right? So in the case of someone who needs to pee, use an antagonist. In the case of someone who has no problem peeing, don't use an agonist. An agonist will make that a problem. So it's all about how you phrase things. So we don't use alpha-1 agonists for urinary incontinence because we're not helping with the detrusor muscle, which is really where we want to go. Okay, hopefully that makes sense. Let's talk about something close by, which is the prostate. So in men, they have an extra gland that sits just below the bladder. And the prostate is like a little donut that surrounds the neck of the bladder. And what happens is that people can develop something called benign prostatic hyperplasia. Benign prostatic hyperplasia, which is the swelling of the prostate. So the prostate tissue swells, which then causes the diameter of the urethra to shrink. And so in BPH, you get urinary retention. So for the alpha-1 receptors in the prostate, once again, you get smooth muscle constriction, which would decrease urinary outflow. So is this situation beneficial in BPH? No. We're taking a situation where someone already has trouble peeing, and we're making it much worse. So a contraindication for the use of an alpha-1 agonist is BPH. They're already retaining urine. Don't make it worse. Now, we can relax the smooth muscle of the prostate. We can make it smaller. And this is going to increase urinary flow. And so one of the beneficial aspects of the alpha-1 receptors, the alpha-1 antagonist is specifically in BPH, which is a kind of urinary retention. Now, what we find in the body actually is that we have two different kinds of alpha 1 receptors. We have alpha 1A and we have alpha 1B. We find that alpha 1A exists both in the blood vessels Oop, you know how I want to do this? I want to do it like a little chart. So we have the blood vessels and we have the prostate. Alpha 1A exists both on the blood vessels and on the prostate. Alpha 1B only exists on the blood vessels. So if you were to pick an alpha 1 antagonist in order to use it for BPH, you would want to pick an alpha 1A antagonist. An alpha 1A antagonist is going to make the prostate smaller. If you choose an alpha 1B antagonist, it's doing nothing for the prostate. Nothing at all. Hopefully that makes sense. Moving right along. We can go to da, 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 da. Let's talk about the eye. So if you remember back in our discussion about the eye, we have the pupil in the middle, and around the pupil we have the circular muscles, and coming off of them are the radial muscles. If you remember, the radial muscles in the middle cause meiosis. They contract inwards. So I think I said the wrong one. The circular muscles on the inside, these cause meiosis, which is the pupil gets smaller. The way I like to think of this is they cause my eye to swell shut, meiosis. The radial muscles on the outside contract outwards. This is going to cause the pupil to get bigger and cause mydriasis. So the pupil gets bigger. So in terms of the eye, radial muscle contraction is going to cause mydriasis, whereas radial relaxation is going to end up causing meiosis, or appears to cause meiosis. And the reason is that the radial and the circular muscles compete against each other, and if you inhibit one completely, then what's ever left over is going to do its job. In this case, cause meiosis. We actually have a use for this, and it's in retinal exams. So where the eye doctor needs to put drops into your eye in order to open up the pupil to be able to see the lens or the retina. Whereas if we give an alpha-1 antagonist, it's actually an adverse reaction that we have meiosis. And what ends up happening is that you can't accommodate for changes in light. So there's no therapeutic use to having your pupil smaller. We don't use alpha-1 antagonists like that. So what that means is that if your pupil gets smaller, in low light, you're not going to be able to see as well. And so that makes nighttime driving much harder. So an alpha-1 antagonist can lead to issues with driving at night, seeing at night. So not a good option for someone who is, who has to work at night, especially driving at night, different stuff like that. All right. Let me just double check. I'm not missing anything. Nope. Great. All right. Let us move on to alpha 2. Now, in alpha 2, part of what is going to happen with alpha 2 is that we're going to end up with constriction initially. But what we see is that alpha 2 is a negative feedback receptor. So let's take a look at what alpha 2 is doing. I think I put it in yellow originally. Alpha 2. So if we draw a simplified version of our smooth muscle, so here we have, let's say, vascular smooth muscle. So the smooth muscle surrounding the blood vessels. We know that through alpha 1, this is GQ linked, which is going to go through IP3, increased concentrations of IP3, which will end up leading to contraction. We also talked about earlier about how alpha 2 is also on smooth muscle, and we're going to cause a decrease in camp, which is going to result in contraction as well, right? By inhibiting relaxation, we're going to cause more contraction. Remember that when we talk about the alpha receptors, and remember my helpful hint here, right, about being, that epi will go to the beta receptors, whereas norepi will go to the alpha receptors. So who is the endogenous ligand for the alpha receptors? Norepi. So when norepi goes to either the alpha-1 or the alpha-2 receptor, we get the same thing, contraction. So for example, here, we have the nerve, and the nerve is going to have that vesicle that's full of norepi. And when the signal comes down, it releases norepi into the synapse, and then we get our stimulation. What's interesting about alpha-2 is that it exists both post-synaptically and it exists presynaptically. What happens with alpha-2 is that it is going to end up opening potassium channels, allowing for hyperpolarization of the cell. Ultimately, what happens here is that we end up stopping the release of norepi. So alpha-2, initially, you get some contraction, but over time, you end up getting less and less and less, which ends up being dilation. So what is the function of alpha-2? The function of alpha-2 is to primarily decrease sympathetic outflow, decrease fight or flight. It wants to prevent tons and tons and tons of norepi activating everything everywhere, preventing epinephrine. Also, it's going to have an effect on epinephrine, decrease that. So it's causing less beta and alpha stimulation. So less sympathetic outflow means decreased alpha-1 and decreased beta-1 activation. So let's talk about the drugs. God, I just cannot draw in straight lines, can I? It's tough. So activating alpha 2 versus inhibiting alpha 2, which is the same thing as saying an alpha 2 agonist versus an alpha 2 antagonist. So let's look at the first location that we can talk about, which is blood vessels. The effect of turning on alpha 2 is that we're going to decrease vasoconstriction. The result is that we're going to decrease blood pressure. So what's one of the uses that we can have for this? Well, hypertension, right? This is a very useful way of having a broader effect on the body through hypertension. The other thing that we find as well, specifically for the heart, is that we're going to decrease beta 1 stimulation, which is going to end up decreasing the heart rate and decreasing the stroke volume. So how hard it is beating, which again, what is the use of this? Hypertension. That's primarily where we're going to be using it. Alpha 2 antagonists would cause the opposite of this, right? They'd increase vasoconstriction, they'd increase heart stimulation. There are no alpha 2 antagonists. There's no benefit to using such a wide-reaching drug. It would just be way too intense. So we do not use alpha 2 antagonists. There's no uses for them. Some of the other things that we end up seeing with some of the alpha 2 agonists, and I'm just going to kind of list them, is in, well, actually, we can talk about the eye first. Let's talk about the eye. So in the eye, alpha 2 antagonists innervate the ciliary body. And what they end up doing is they decrease aqueous humor production. And think about this for a second. What is alpha 2 doing? It's decreasing the outflow of beta and alpha stimulation. So if you remember, it was the beta 2 receptor that increased aqueous humor production. So what's happening here is that we are decreasing beta 2 stimulation, which is decreasing the aqueous humor production. So where is this useful? Glaucoma. Specifically the drug apraclonidine, which I believe is a modified version of clonidine that prevents it from systemically being absorbed, I think. Now, there's a couple of other effects. We can use alpha 2 agonists like clonidine in ADHD because it's a bit sedative. We use it in withdrawal from certain narcotics because, again, we're decreasing the sympathetic activity, and it's also sedative. So, quite nice, right? Quite nice. All right. All right. Let us do. Ooh, I wonder if they're talking. You're gonna talk about probably. Yeah, we'll just talk about it. We'll go through it. No. Are you gonna go through? Let me pause real quick and check. All right, I was gonna double check to see if you guys were gonna go on to pressers, but I don't think you are for this exam. So I'm not going to worry about that for now. But if things change, obviously let me know. So hopefully this explanation of the alpha drugs makes sense. Be on the lookout for on the classroom that I'm going to post a couple of fillable charts to help you guys with studying. And good luck. I will see you on Saturday. Goodbye.